Last presenter for this session is Dr. Komal Jhaveri from Memorial Sloan Kettering Cancer Center. She'll be in person, and she will discuss Neratinib plus fulvestrant plus trastuzumab for hormone receptor-positive HER2-mutant metastatic breast cancer and Neratinib plus trastuzumab for triple-negative disease. Latest updates from the SUMMIT trial. Dr. Jhaveri.
Thank you so much. I'd like to thank, on behalf of all my authors, to the organizing committee and to our study chairs for this opportunity to present the latest updates from the breast cancer cohorts from the SUMMIT trial. These are my disclosures. HER2 overexpression and/or amplification has a multitude of therapeutic options, but somatic mutations in the ERBB2 or the HER2 gene, in the absence of HER2 overexpression, can also amplify signaling. In fact, HER2 mutations are relatively rare, occurring in about 2 to 12% of solid tumors, depending on histology. Neratinib is an oral irreversible pan-HER tyrosine kinase inhibitor that is already approved in early and late-stage HER2-positive breast cancer. Preclinical and clinical data suggest that somatic mutations do lead to resistance to prior endocrine therapy, and they can confer resistance to that prior endocrine therapy, but they can retain sensitivity to Neratinib. And to that end, clinical activity has been reported with single-agent Neratinib or in combination with fulvestrant in HER2-mutated, HER2 non-amplified metastatic breast cancer. And early data also suggests that the triplet of Neratinib, fulvestrant, and trastuzumab may be effective based on the reports from the SUMMIT cohorts and also the MUTE-HERS trial. In breast cancer, these mutations are enriched in metastatic lobular cancer, and the prevalence can be as high as 15%. The most common variants are usually single nucleotide variants in the kinase domain, in-frame exon 20 insertions, and S310 mutations in the extracellular domain. And common co-mutations include P53, PIK3CA, ERBB3, and CDH1 mutations. The SUMMIT trial began several years ago, and it began as a hypothesis-generating basket trial to investigate if patients whose cancers harbor HER2 mutations can benefit from single-agent Neratinib. Patients with metastatic cancer with a qualifying HER2 mutation detected in tissue and/or plasma from a local test were eligible to be enrolled to the SUMMIT trial and received Neratinib 240 milligrams orally daily with loperamide prophylaxis. Patients with breast cancer also had to be HER2 negative by IHC and/or FISH using the ASCO-CAP guidelines, and prior treatment with any pan-HER tyrosine kinase inhibitor were excluded. Patients were enrolled to a histologically defined cohort on a Simon two-stage design with a primary endpoint of objective response rate. Now, the breast cancer cohorts have really evolved during the time of the SUMMIT trial. Originally, with hormone receptor-positive, HER2-negative, HER2-mutant breast cancer, single-agent Neratinib monotherapy revealed an overall response rate of 17% and a median progression-free survival of 3.6 months. With metastatic triple-negative breast cancer that were HER2 mutated, single-agent Neratinib demonstrated an overall response rate of 20% and median progression-free survival of 2 months. Fulvestrant was added to Neratinib to take care of the detrimental impact of the HER2-ER crosstalk, and this did improve the overall response rate to 30% and the median progression-free survival to 5.4 months. Of note, in this cohort, 14 or 37% of the patients had received prior CDK4/6 inhibitors. Paired tumor biopsies and pre- and post-treatment plasma samples revealed acquisition of one or more new HER2 mutations and/or amplification of the mutant allele. And beyond amplification on the HER2 on-target signaling, there was no other broad pattern observed. Preclinical data also suggested that Neratinib in combination with trastuzumab was superior than either agent alone in HER2 mutant cancer. We therefore investigated if dual targeting of HER2 with the addition of trastuzumab to neratinib-containing regimens would be more effective. For the hormone receptor-positive cohort, we also included prior CDK4/6 inhibitor therapy as an eligibility criteria to reflect the current standard of care. Now, to specifically address the contribution of neratinib to this therapy, we then included a small randomized Simon two-stage comparison of 7 patients each looking at the triplet of neratinib plus fulvestrant plus trastuzumab versus fulvestrant plus trastuzumab doublet versus fulvestrant alone. The non-neratinib containing randomized cohorts could then cross over to receive neratinib at the time of clinical progression. Patients with metastatic triple-negative breast cancer with HER2-mutated disease were treated with neratinib in combination with trastuzumab. These are the key baseline characteristics and prior therapies for the hormone receptor-positive cohort. The first column represents the 26 non-randomized patients who received the triplet regimen prior to initiation of the randomized cohorts. These are the 3 cohorts of the randomized that are seen next on the table, with the triplet regimen, doublet of fulvestrant and trastuzumab, and single-agent fulvestrant. These patients had received up to median of 3 to 6 prior lines of therapy, and all patients had received prior endocrine therapy and prior CDK4/6 inhibitor therapy. This last column are patients, which is a combined analysis of non-randomized and randomized cohorts, which received the triplet regimen of neratinib, fulvestrant, and trastuzumab. And for these 33 patients, these patients had received 5 median prior lines of therapies, 82% had received prior fulvestrant, and 82% had received prior chemotherapy. Investigator-assessed objective response rate for the 26 non-randomized patients who were treated with the triplet regimen demonstrated an objective response rate of 46%, a clinical benefit rate of 58%, and a median progression-free survival of 8.2 months. These are the efficacy results for the randomized cohort. There were 2 patients who had responses with the triplet regimen, including 1 complete response, and no responses were seen in the non-neratinib-containing regimens. This proves the hypothesis that neratinib appears to be critical for the inhibition of HER2 mutations. And based on these results, the Independent Data Monitoring Committee recommended to close the non-neratinib-containing cohorts and to further expand the triplet arm. These are the efficacy analyses from the non-randomized and the randomized combined patients who received the triplet regimen. And for these 33 patients, the objective response rate was 42.4%, clinical benefit rate of approximately 52%, and median progression-free survival of 7 months. Now, to put these data into context, these are the 14 patients who had received prior CDK4/6 inhibitor therapy and were treated with the doublet of neratinib plus fulvestrant on a prior summit cohort where the objective response rate was 29% and the median progression-free survival was 2.9 months. The spiders plot here, the patients are depicted as a different color, and they reveal that there were deeper and longer responses seen with patients treated with the triplet regimen in the randomized and the non-randomized cohort as shown on your left, compared to those patients in the non-neratinib-containing randomized cohorts on the right. Despite required loperamide prophylaxis, diarrhea was the most common adverse event seen in 91% of the patients, with 46% having grade 3 diarrhea. There were no grade 4 diarrhea events. The median time to first diarrhea event was 4 days. Median duration of each episode of diarrhea, which was grade 3, was 2 days. The cumulative duration of grade 3 diarrhea throughout the course of the treatment for a patient was 4 days. 7 or 21% of the patients required 1 or more dose reductions. There was 1 discontinuation due to diarrhea and 1 discontinuation due to asthenia and nausea. Now, for the HER2-mutated metastatic triple-negative breast cancer cohort, these patients had had 3.5 median prior lines of anti-cancer regimens prior to enrollment. And the objective response rate in this cohort was 33%, with a clinical benefit rate of 39% and median progression-free survival of 6.2 months. Grade 3 diarrhea in the metastatic triple-negative breast cancer cohort was about 17%, with no grade 4 diarrhea and no patients requiring discontinuation due to any adverse event. These are the waterfall plots that are categorized by cohort. On your extreme right is the triple-negative breast cancer cohort, and these cohorts are also color-coded by the HER2 mutation allele. Tumor shrinkages were noted in patients whose tumors harbored oncogenic mutations across all domains. It was interesting to see that responses were seen for both ductal and lobular histologies, and these responses were also seen despite co-mutations in PIK3CA and ERBB3. These lollipop plots suggest that HER2 mutations were distributed throughout the kinase, transmembrane, and the extracellular domains, and responses were reported in patients with HER2 mutations in any of these domains in all neratinib-containing cohorts. So in conclusion, the combination of neratinib plus fulvestrant and trastuzumab demonstrated encouraging clinical activity in patients with heavily pretreated hormone receptor-positive, HER2-negative, HER2-mutant metastatic breast cancer who had previously been treated with CDK4/6 inhibitor therapy. The objective response rate here was 42%, and median progression-free survival was 7 months. Following guidance from the Independent Data Monitoring Committee, the non-neratinib-containing randomized cohorts were closed. For metastatic HER2-mutated triple-negative breast cancer, the combination of neratinib plus trastuzumab also showed promising clinical activity with objective response rates of 33% and median progression-free survival of 6.2 months. Grade 3 diarrhea was higher than is anticipated with the triplet combination, and compliance with loperamide prophylaxis is imperative. With respect to next steps, following closure of the non-neratinib-containing arms of the randomized cohorts, additional patients with hormone receptor-positive, HER2-negative, HER2-mutant breast cancer with prior CDK4/6 inhibitor therapy have been enrolled, totaling to a number of 50. The safety and efficacy outcomes of who will be evaluated. We will also continue to enroll patients with triple-negative breast cancer who will receive treatment with neratinib plus trastuzumab. Further, we will assess patients with hormone receptor-positive disease who crossed over after progression on the non-neratinib-containing arms and derived benefit with the triplet regimen. It'll be important to incorporate neratinib dose escalation as defined in the control study for a recent update to the US package insert to further optimize diarrhea management. And last, prospective central testing and companion diagnostic development will also be considered to be incorporated for submission to the regulatory authorities. The authors would like to thank all patients and their families for participating in Summit, and thank you all for your attention.
We have several microphones, Dr. Ugo.
Excellent work and nice presentation. Really quite intriguing data, particularly looking at the trastuzumab endocrine cohort, although very small numbers. So 2 questions for you. The first is, why do you think there was such a difference in grade 3 diarrhea between the triple negative and the hormone receptor positive cohort? We don't think of fulvestrant as causing diarrhea, and that's the only difference in the cohort except for numbers. And I mean, do they already have diarrhea beforehand? So they didn't report it as much. And would you consider starting at a lower dose? Because a 50% rate of grade 3/4 diarrhea may not be controlled by the controlled trial type dose escalation. The second thing is, these are remarkable results, long PFS. Is it ready for prime time? It's still being studied, but what about that patient who comes to you and has a somatic mutation tomorrow?
Thank you. Excellent questions, Dr. Ugo. So to address your first question, it does appear that the grade 3 diarrhea events were higher with the addition of trastuzumab. So as a reminder, when we think about the external trial where we did not incorporate loperamide prophylaxis, the grade 3 diarrhea rates were 40%. Subsequently, when we had incorporated loperamide prophylaxis into the trials requiring neratinib, the diarrhea rates ranged between 16 to 31%. Now, in the triple-negative cohort, that kind of matches what our experience has been in the past with 17% grade 3 diarrhea. It does appear that the addition of trastuzumab has a further additive or synergistic effect and makes the diarrhea worse. Having said that, I'd like to point out in the 7 patients that were the randomized patients that received the triplet, 5 out of the 7 that were enrolled over this past year and a half did have grade 3 diarrhea. And this makes the diarrhea a grade 3, 71% for those patients. So it's kind of skewed with that population. The non-randomized cohort that had that was conducted prior to the randomized initiation, 10 out of the 26 of those patients also had grade 3 diarrhea, so that's about 39%. So certainly more than what we have seen. There might be some contribution from trastuzumab, and it is certainly possible, since this is a data snapshot and not complete data cleaning at this point, that given the pandemic, what we have noticed is the compliance with the loperamide was not necessarily optimal, and no additional antidiarrheal agents were considered. The dose hold or continuations for grade 2 and grade 3 diarrhea varied for patients. So it would be very imperative for us to look into the loperamide prophylaxis and compliance with that, optimize the supportive management, and incorporate the dose escalation strategies that control use to see if we can further limit this diarrhea events.
I just wonder if maybe the next step in the trial is to look at a lower dose. I mean, it doesn't really matter. You can take all the loperamide you want. Having that much diarrhea is still miserable, as is the loperamide. So maybe this would be as effective at a lower dose, since most patients are going to be skipping and lowering the dose all the time.
Yeah.
And would you do this outside of a clinical trial tomorrow?
So at this point, I'm not doing this outside of a clinical trial, but I do agree that this seems to be a finding that we are really seeing consistently with this drug, and the efficacy certainly we are seeing even in a post-CDK4/6 inhibitor patient. So it certainly is tempting, but we're continuing to do that over a clinical trial at this point.
Okay, question.
Yes, Hassan Ghazal. Nice, very nice presentation. I had a question. So if we look at other cancer types with HER2 mutants, like in lung cancer, there was actually very high activity of TDXD. So what's your, do you have any vision that this drug may be active in breast cancer as well, in the HER2 mutant?
So that's a very fantastic question. I completely agree. We have activity for antibody-drug conjugates in HER2 mutant cancers. Our institution, led by Bob Lee, the effort for TDM1 was also reported and published for HER2 mutant lung cancers, where they demonstrated a response rate of 44% for HER2 mutant lung cancer. And we also have laboratory data from our institution that when we combine neratinib with antibody-drug conjugates, there is further internalization and further improved efficacy would be expected. So I think it's great to have options for our patients. I do think that antibody-drug conjugates are here, and they would be effective potentially in HER2 mutant cancers. TDXD is being evaluated in HER2 mutant solid tumors in a basket study as well. And so the hope is that perhaps we can use these therapies sequentially and further improve outcomes for patients with HER2 mutant disease.
Mohammed El-Nagi, New York. Thank you for touching on a new aspect of HER2 implications in cancer, but I have a number of questions, actually.
We have very little time, so make it short.
Trastuzumab binds to the extracellular domain, and if you have mutation there, how do you explain its work? That's one thing. The presence of mutation in HER2 doesn't mean that it is a driver mutation. And can you give some comments?
Right. So in this trial, we allowed patients with HER2 mutations that were characterized to be hotspot mutations and oncogenic drivers. And so while we allowed patients to be enrolled based on the local assay, we ensured that they actually matched the characterized oncogenic mutations that we know of already. And additionally, pre-treatment biopsy samples were also mandatory so that we could do central HER2 confirmation in the tissue. And so we plan to do that to confirm that as well for our patients.
Okay. Real quick, one more. Real quick.
Thank you for your presentation, Sujin Tan, Mississippi. We know that the activity of trastuzumab in IHC 0 tumor are very low. And I wonder if you look at your subgroup to see if there's a difference in efficacy of your triplets in patients whose tumor has IHC 1 versus 2 versus 0.
That's a fantastic question. As I said, we have collected pretreatment tissue samples from all our patients for confirmation of HER2 mutation status. We also plan to conduct HER2 testing by IHC and FISH centrally and plan to correlate them with responses based on the IHC categories and the FISH ratios and copy number. I do not have that data to date, but we hope to present that at a future meeting. Thank you.
I will close by asking a very quick question with a very easy answer. In your general practice, do you test for HER2 mutations at the time of metastatic disease diagnosis?
Yes, so we certainly send next-generation sequencing for various reasons in breast cancer, for PIK3CA mutations, now for ESR1 mutations. And based on that comprehensive genomic profile, we do get the data on HER2 mutations, which facilitates enrollment on trials.
Thank you very much. Thank you for an excellent presentation.
Thank you, everyone.